This material is for reference and educational purposes only. SimKit, its authors, and associates assume no responsibility for the utilization of any knowledge, materials, or techniques shown or described, nor do SimKit, its authors, or associates assume any responsibility for patient safety or outcomes. Clinical experience as well as current guidelines should determine the exact procedure and processes in each individual patient.
All right. Ready to rock and roll?
Yeah, man, let's do it.
Hello, everybody, and welcome back to the SimKit podcast. Today we are going to be talking about a very interesting case, I believe, and we have our special guest, Dylan War, who has graced us with the Acorn review that we had from earlier in the podcast series. Thank you much for joining us, Dylan, and tell the listeners a little bit about yourself.
Hey, Jason. Yeah, thank you for having me. It's always been a pleasure to get a chance to talk to you and sort of share what's been going on back in our emergency department and your alma mater. We have a really cool case to sort of discuss today, and it's pretty multifactorial, and I think it gives us a good chance to talk about differentials and then cover a really rare but also really important diagnosis that we see in the emergency department.
Perfect. Yeah, and so obviously in the title of the podcast, you know, we're going to be talking about Myxedema Coma. That's going to be an element of our conversation, but I'm going to be putting myself a little bit in the hot seat here with Dylan. We're going to kind of do an oral boards review type case presentation, work our way through, think about all the things that went into the care of this patient, and then Dylan's going to wrap it up with some summary points. So Dylan, tell me a little bit about this gentleman.
Absolutely, Jason. I want to preface this case presentation by acknowledging that this was a patient who was ultimately admitted to our medical ICU while I was rotating on that service. The collective "we" used when discussing this case refers to collective actions by the amazing emergency department team in addition to care rendered by our medical ICU colleagues after the patient was admitted to the unit. I want to also acknowledge the phenomenal work and clinical decision-making of the emergency medicine intern rotating with me on the service during the care of this patient. All right, Jason, so let me lay the scene here for you.
Paint me a picture, yeah. Paint me a picture.
As bright as I can. So you're overnight.
Okay.
Right? This is a 69-year-old male who's coming into the ED. He's brought in by EMS. Chief complaint, altered mental status. You kind of do a little bit of a chart review as EMS is sort of putting him in the room. He has a history of ESRD on hemodialysis, hypertension, and alcohol use disorder. Kind of seems like it's documented at 1 pint per day, and hypothyroidism. You go into the room, you talk to EMS. For them, the patient was last seen normal by his sister 4 days before this presentation. And then that day, he was found by his landlord confused and disoriented. EMS thinks the patient likely missed several dialysis sessions, also known to still drink pretty heavily, at least per the sister's report when they talked to the sister. Otherwise, you're really not getting much from the patient. He's pretty disoriented, he's incoherent, but he's denying missing dialysis and he's denying pain when you ask him. You go back to the computer, you do a little bit of a deeper dive. It seems like he had a similar presentation 7 months ago, where he also was found minimally responsive at home, found to be confused with hypoglycemia and volume overload from what everyone assumed was missed dialysis. And then he left the hospital a couple days later after multiple dialysis sessions. And that's really all you get from him.
Lovely. Okay, so nice and easy. Simple case. Narrow differential. All right. Tell me give me what the patient looks like in the room, what you get for vital signs, etc.
Yeah, so you go into the room. Patient is sort of sitting there, really not doing all too much. He's moving all of his extremities. He's looking around the room. He's muttering. You really don't get much from him. You throw him on the monitor. His heart rates are in the 20s to 30s, which, always gets your pulse going up even if theirs is pretty low. His blood pressure systolics were in the 80s. He was breathing at, the standard 16 to 20 breaths per minute. And he wasn't doing the best with his oxygenation. Nursing ended up needing to throw him on 6 liters nasal cannula to get his oxygen saturation maintained at 98%. And then when they went for the thermometer read basically too cold to read. And just for context, it was about 25 degrees Fahrenheit outside. It's sort of the winter.
Okay. All right. So some information there. We have a bradycardic and hypotensive patient, so that's going to obviously increase our concern and our sphincter tone a little bit. And I like that you said that he's moving all extremities, that it doesn't appear that he has one side that's down versus the other. Granted, you said he's 4 days into his presentation, so our urgency related to that is not as high, but I like that he is at least symmetric in his neurologic examination. Tell me in a general sense in his appearance, are you seeing any signs of trauma? And can we kind of work our way through a physical exam?
Absolutely. So you take a look at him, no obvious trauma anywhere. So you kind of go top to bottom. His pupils are equal, round and reactive to light. You try to do some extraocular motion testing, but he's not following commands. You do note that his tongue and lip look a little large, don't really know what his baseline is. They're a little bit swollen. Though, despite the swelling, he's tolerating secretions. There's nothing really red or purulent that you see. You get him to open his mouth after a bunch of commands and stimulation. You see his uvulus midline. You're able to see the back of his throat. You listen to his heart, bradycardic, no surprise there. You note a hemodialysis line right on his anterior chest. Pulmonary, no respiratory distress. He's not breathing particularly fast or like he is hungry for air, but you do note some coarse crackles bilaterally. His abdomen's soft, it's non-tender. Then MSK-wise, you note some 2+ pitting edema in his bilateral lower extremities, but kind of overall mildly anasarchic. He looks a little puffy throughout, but it's kind of seems pitting from your initial examination. And then skin is dry, it's cool, and no obvious redness or rashes that you can see. Now, you try to do a neuro exam. He knows he's in the hospital. He knows his name. But other than that, you're not getting that much from him.
Okay.
And that's really where we are at this point with your initial evaluation.
All right, good. That we got that physical exam through quickly. We can certainly consider in our oral board style checking his points of access. So making sure that he has 2 large bore IVs. He is probably been put on telemetry, but we're going to verbalize our need for tele and ask for an AccuCheck and an EKG pretty readily on this patient. With his vital sign abnormalities, I'm going to have nurse make sure that we have atropine at bedside as well, and probably place pads given the soft blood pressure and the bradycardia as we move forward with this person. So EKG and glucose would be my first points of assessment in this guy.
You get an AccuCheck, it's 14.
Okay, that's a good start. 14, good. We can certainly use the D50. We can talk about a little, sometimes those larger boluses of sugar can lead to a hyperglycemia, insulin release, and then worsening hypoglycemia later. So sometimes I move towards maybe a drip of D10, but in this case, let's move forward with some D50 as we work on getting our EKG.
So you give the D50, and we thought about doing something very similar, especially given his ESRD and our concern for maybe fluid overload for him. We didn't want to give him any excess fluid in this case, so we try to keep it as concentrated as possible, at least in terms of his glucose bolus here. So you get an EKG. It's bradycardia with some prolonged QTC, kind of 490, close to 500 in terms of his QTC. Otherwise, nothing particularly remarkable besides sinus bradycardia.
Okay. So hypoglycemia, sinus bradycardia with a long QT, and definitely some concern about his vital signs. He is bradycardic hypotensive, and pain is not our 5th vital sign here. We're going to be looking for that temperature. So trying to get a sense of the temperature in the gentleman. I'm probably going to ask for a Foley temperature probe as we move forward. And just thinking about this guy globally, very broad differential diagnosis. So he's a gentleman with, first let's go back and say, clearly he drinks, he's intoxicated, that's it, we're done. Call him intoxicated, wait for him to sober up, check on him in 6 or 7 hours and make sure things are better, right? That's the end of the case conclusion.
I wish that was the case.
All right, so his actual differential, so end-stage renal disease, he's bradycardic. We talk about, hyperkalemia as a great masquerader. Sounds like you're not describing peak T waves or a wide QRS, which is good in this circumstance, but not our endpoint. So we have to think about his potassium affecting his vital signs and his heart rate. I also think about uremia, certainly in this guy who possibly missed a bunch of dialysis. Talked jokingly about alcohol, but we have to think about an intoxicated state, or if he was a drinker and he's been actually not able to consume for the last 4 days, he could have a alcoholic ketoacidosis, starvation ketosis, that's all on there. And I'm thinking a little bit about, you said he has hypertension and he has low sugar, low heart rate, low blood pressure. So we're definitely going to be doing a pretty decent medication review, thinking about digoxin, calcium channel blocker, beta blocker, clonidine, either taken in excess, maybe related to confusion, or accumulated from missed dialysis. Exposure, purely just being cold. It sounds like he was found indoors, so less likely with that outdoor temperature affecting that. That's on there. Sepsis with the low blood sugar is going to be on his list as well. And you mentioned the hypothyroidism. We're wondering about his medication compliance or if he's able to take it. If we could see why he's hypothyroid in the past, what led to his hypothyroid state, that would help me too. But we're going to have to think about a pretty profound hypothyroid. And with his vital signs and his mental state, we're talking about myxedema coma. And then you can't mention that without talking about adrenal insufficiency, because that comes up too. Trauma doesn't sound like it's a major concern, but I think with his mental state, we're going to be checking a head CT there. That's what I got for a differential so far, which is broad. And in evaluating it, let's think about what we want for assessments. Talked about his sugar and his EKG, which we've done. I'm going to get a chest x-ray probably because of his oxygen requirement in his bibasilar rails. Mentioned a head CT to make sure he doesn't have a bleed. Going to be looking for a CMP, a CBC. With his vital sign abnormalities, certainly, adding a troponin. We don't know about his story for any cardiac disease, but if he's taking out his AV node or having other Brady dysrhythmias related to that, I don't think a troponin is a bad idea. Hopefully we have priors in this gentleman with end-stage renal disease. I'm going to ask for a lactate. We can do a VBG when we pull his labs. And of course, I'm going to be looking for a TSH and a T4. And let's pull some cultures while we're in there as well.
All right. What would you like to know first?
Well, this is the difference, oral board versus reality. I want to see them as they come back in real time. I think we do need to check and verify that his hypoglycemia has resolved. So I think we should recheck his AccuCheck and do a quick mental status assessment, see if he's gotten better when his sugar is not 14.
Give him that B50 push. He doesn't get any better in terms of his mental status, but his repeat AccuCheck is normal. It's like 90s to 100s.
Okay. So we normalize that and he is still altered.
Yes. So we get that chest x-ray. It's notable for some bilateral infiltrates. Kind of seems consistent with pulmonary edema. You get him over to CT head. Everyone's pretty concerned about him, so he goes pretty quickly, comes back. You don't see any obvious bleed or acute process on that CT head. Labs start coming back. A sodium of 141, a K of 6, chloride of 114, his bicarb is 14, is a BUN of 95, and a creatinine of 13.7.
Let's pause on that for a second. The sodium is super irrelevant, I think. Hyper or hyponatremia as an electrolyte derangement is definitely a consideration in this case. I'm happy to see his K is 6, not 8.9. A bicarb of 14, not the worst in the world, so those are some good numbers there. A little bit of reassurance and maybe narrowing of our differential. Creatinine of 13, we expect that. How about his CBC?
He came back with a white count of 8.9. His hemoglobin is 7.9, which is stable. You look at it, the couple recent presentations are all in that 8 to low 9 range. Platelets of 273.
We're working our way through troponin. Is that coming back at all?
Yeah, the troponin is 14, just mildly above our cutoff for high sensitivity to troponin, all pretty consistent from prior presentations.
And if you considered it or if you wanted to add it on as we're throwing a lot of labs at this guy, an ethanol level certainly is something you think about in terms of his mental state. Is it going to answer all the questions, or if it's elevated, are you done? No, but it comes into play. And then you also think about it if he has a significant anion gap and you want to try to figure out why, if you want to add up the pieces to that.
Lactate comes back at 0.8.
Okay.
We added a BNP as well, a natriuretic peptide, just given his volume overload state, and we were kind of working through differentials. That came back at 1791, which was very elevated for him compared to prior. But it sounds like he kind of bumps every time he comes in, volume overloaded in the setting of missed dialysis.
Sure.
His gas, which you asked for, his pH was 7.16 with a PCO2 of 41. And a bicarb there of 15. Blood cultures are obviously pending. He had some mild elevation in his transaminases on his LFTs. And then the TSH, which luckily in our shop comes back pretty quickly compared to maybe elsewhere, came back at 9.8, which is elevated, sitting in red. T4 is still pending at this point.
Okay, so elevated TSH, not the highest number I've seen, but 9.8 in this clinical context definitely raises your eyebrows some. You can say we took trauma off the list, or at least intracranial hemorrhage off the list in that way. significant hyponatremia off the list. BUN of 95 in that guy, it's something that we think about in terms of it causing an altered state. We want to see its comparison to prior when he's presented like this. But some uremia, if we're talking about a mixed picture, is going to come into play. Hypoglycemia, we're removing from it. A significant anemia, we're not seeing that. It looks like he does have a volume overloaded state, or at least a stressed heart in that BNP, which we probably recognize as well just in his bradycardia and his rails on exam and his chest x-ray showing that pulmonary edema. And kind of reassured of a troponin of 14 in a guy with end-stage renal disease. So right now, still thinking a fair bit about his thyroid. We are going to be doing a med rec, obviously, as we go through and look for any potential medications that might be missing from him that he needs, as well as ones that might be an overdose. So with the bradycardia hypotension, looking at calcium channel blockers and beta blockers, if those are on his list. As with the low blood sugar, we're going to be thinking a bit about a beta blocker toxicity or overdose in this case as well.
Absolutely. You look at the dispense report and he is, from what you can tell, he's taking aspirin, he's taking famotidine, he has amlodipine on his med dispensement report, and levothyroxine. From what you can tell, all these were kind of filled maybe 3 months prior to this presentation, with all of his meds listed for about 30-day supply.
Okay. And in this patient who is, bradycardic hypotensive, we do probably want to do a rush exam. Definitely would want to see some ultrasounds in this guy. We're thinking about his uremia, right? And we're thinking about hypothyroidism. So I want to get a look at his cardiac silhouette. I want to make sure that he doesn't have a significant pericardial effusion, which might be complicating his hypotension, and doing the remainder of the rush looking for, free fluid in the abdomen. We're not really thinking about AAA, but looking for DVTs, looking for fluid in the belly, looking for pleural effusions, seeing their size comparison to an X-ray, and a really strong focus on how his heart is squeezing and if there's a pericardial effusion.
Yeah, Jason, we ended up getting a bedside ultrasound on this guy given his hemodynamic instability. We didn't do a full rush. Thinking back on it, I think it would have been a really good way to approach his hypotension. We had sort of been thinking more about why is he volume overloaded and ruling out some of the other differentials when it came to his elevated BNP. We took a look at his heart. It actually had a pretty decent squeeze and no pericardial effusion. We did note diffuse B lines bilaterally, kind of in the upper and lower lobes. Definitely more consistent with pulmonary edema. No obvious pleural effusions that we saw in this case.
Okay. We have a pretty good differential. It's actually narrowed down somewhat in our initial assessments, which is great. I think we need to start thinking about our interventions on this gentleman. I'd like to push that amp of atropine and see if he has any response to that. Certainly be keeping tabs on the trend in his blood pressure and if he's becoming any more hemodynamically unstable. It sounds like this is less likely intrinsic heart damage or things in that way, probably more on the cellular level when we're thinking about myocyte dysfunction. Pacing him through that, I don't have a great interest in doing so at this point, so long as his blood pressure stays in the high 80s, low 90s in that area, and he's not getting worse. And then potassium of 6.0, certainly can consider treatment thereof. It's elevated, not markedly so, but something, as we talk about this multifactorial approach, and we're talking about some hyperkalemia, I would go forward with giving this gentleman some calcium to see if it affects his EKG in any way.
We did push calcium. We pushed some sodium bicarb as well, just because we had no idea what was going on with him. We see a lot of people, unfortunately, who miss dialysis at our shop. So we very often empirically treat for hyperkalemia when people come in who are ESRD and have odd findings on their EKG. So we get calcium, he got sodium bicarb, we gave him Lokelma too, it's part of our pathway. Given his hypoglycemia, we deferred insulin and dextrose. It's usually part of our cocktail, but we proceeded to avoid that in this case. We did end up giving atropine, given he had very little improvement with the hyperkalemic interventions, and his bradycardia did improve transiently. It went up to the 70s to 80s for some time before settling back down in the 30s to 40s.
So definitely, it's great to have that sort of ray of light, noting that he responds to atropine and having that in our back pocket in case he decompensates further. But our differential right now, as I see it, end-stage renal disease, missed dialysis. We were certainly thinking a fair bit about hyperkalemia with his bradycardia and his hypotension. Thinking probably a little less about that with 6.0. It's not markedly elevated, or we certainly need to think about it in comparison to his priors. But end-stage renal disease are pretty tolerant to that, and not a markedly elevated number. Seems like our interventions in that capacity may be not super effective, but we do still need to think about uremia as a cause for his mental state. And so we're going to be getting nephrology on the horn to talk with them about the timing of this guy's dialysis. Alcohol use disorder, sure, it's always on there. An elevated alcohol level is probably going to only lead us to think of a mixed picture of altered mental state. His labs don't really suggest like an alcoholic ketoacidosis, which is great. We are on a calcium channel blocker, but we are reassured that, he is, I guess, reassured that he's hypoglycemia. He doesn't have beta blockers in his system, and so that is less of a consideration or concern. Sepsis, always there. Got to think about it. We're going to pull our trigger on treating with broad-spectrum antibiotics. We have our blood cultures running, and we're looking for any potential source of infection there. Purely being hypothermic is a consideration in this guy, but doesn't really necessarily sound like that's a high clinical concern given that he was not found outside or had a specific cold exposure. And then, adrenal is going to be considered on that, as well as myxedema coma, and starting to look more and more like that is our potential root cause as we look at his TSH and his past medical history. So we're definitely going to get endocrine on the horn as we sort of narrow down on this potential differential for him. Dylan, anything on that list that you have qualms with, or anything you'd want to add or expand on?
Yes, happy to expand a little bit more on the differential as we have it at this point. I think to start, I would love to just expand a little bit more on your discussion about calcium channel blockers and beta blockers. Calcium channel blockers and beta blockers are really important to think of and consider when someone presents with hypotension and bradycardia. A commonly tested association of these medications has to do with their effect on blood glucose. Often, you can hear calcium channel blockers being associated with hyperglycemia, while beta blockers are more associated with normoglycemia or hypoglycemia. Just for fun, I'd also like to talk about and just throw out Brash syndrome as something that we need to consider in this case. Remember, this relatively new syndrome goes by this acronym, which stands for bradycardia, renal failure, AV nodal blockade, shock, and hyperkalemia. And this patient does meet all of those criteria, including taking a calcium channel blocker, which can impact your AV node. Now, we do know he has ESRD at baseline prior to this presentation, so that makes all of this a little bit less likely. So one additional thing I would like to hit on here is the physical exam. We didn't really touch on it much during the discussion of the differential diagnosis, and I think it really plays a role in determining what may be the ultimate diagnosis in this case. For example, in this physical exam, we were unable to properly assess extraocular movements given the patient wasn't following commands. We also couldn't assess gait to find out if he was ataxic. We couldn't do finger to nose testing. Therefore, in someone with alcohol use disorder, are we missing Wernicke's encephalopathy? I think when we think about differentials, we also have to highlight this potential pitfall with the patient being volume overloaded. He clearly is volume overloaded on exam. He has 2+ pitting edema in his bilateral lower extremities. He has coarse rails in his bilateral bases. He even had a bedside ultrasound with diffuse B-lines. All of this screams you miss dialysis. You have volume on board. Yet, how do you explain the enlarged swollen tongue and lower lip and this general full body puffiness, for lack of a better word? It really makes you stop and think, is this myxedema coma?
Yeah, that's fair. And as we work through our, cognitive processes, we obviously need to consider and act as well, and act quickly. And then in the emergency department, we are the master of the undifferentiated, clinically very ill patient. So I think as we continue to consider, uremic encephalopathy, adding Brash syndrome to consideration, myxedema coma, and adrenal insufficiency, we're going to get the bear hugger on this guy as we go back to our sort of oral boards formatting. Love to see what his temperature is by temp Foley or other means of kind of consistent measurement there. It looks like his hemodynamics are maybe improving a little bit, or at least stable. I don't think we need to go to, active rewarming. We're not putting chest tubes in this guy to irrigate the central system.
I hope not.
But we want to start warming him up, talking to our colleagues in nephrology and endocrine. And when we do that, as we talk about talking to endocrine and considering adrenal insufficiency, we're going to add cortisol as a test that we want to add to his labs.
For sure. So you throw a bear hugger on. It's been a little busy in the emergency department. Nursing has had a hard time getting an active temperature. So we are empirically treating for hypothermia at this point. There's a bear hugger in place. The repeated oral and rectal attempts at temperature sensing really just continue to read temperature not detectable. We reach out to nephrology. The patient gets put in a hemodialysis capable emergency department room, and the dialysis nurse comes down and we get the party started, and we're at least having one intervention in place and one of the possible solutions to this presentation ongoing, with some labs still to come.
Perfect. Well, I'd say that we're covering some of these bases empirically already, right? So sepsis, we're treating it broad spectrum antibiotics. Temperature exposure or just pure hypothermia, we're rewarming him. And the dialysis is now ongoing. So that leaves us to sort of consider and think about the adrenal insufficiency and the myxedema coma. And probably in this critically ill patient, we need to be aggressive and early in our therapies. We've pulled all of the necessary labs so that we're not making it more difficult for our colleagues down the road. So I think it's okay to start giving treatment. And treatment in this way, in my mind, are steroids and T4. So that would be the direction I would go if we can get in touch with endocrine as we sort of get ready for this administration of therapy. And then we'll have a conversation with them about T3 administration given the critical illness in this patient. But that's a decision I'd like to make with endocrine.
Dialysis ongoing. You reach out to endocrine, and sort of as the time of you're deciding to give endocrine a call, the T4 comes back very low. You sort of have another thing in your toolbox here, potentially pointing you in the direction of myxedema coma. So you talk to endocrine, they agree, let's check a cortisol, let's get an ACTH. They recommend getting, another free T3 before initiating treatment. They want all of their baseline labs. They are of the opinion and sort of hedging their bets as well when it comes to this presentation. They're like, yeah, maybe it's multifactorial. This is a endocrine emergency that we can't ignore in this case. So they agree with you, Jason. They want us to give stress dose steroids, and that's the first thing we give. So they recommended hydrocortisone, 100 milligrams. We kind of went back and forth in terms of dosing. We set it on Q8 hours, right after labs are drawn. They agreed with us in regards to giving levothyroxine. We gave a loading dose, and then we sort of planned to give repeat doses daily thereafterwards. And you're right, we did need to kind of go back and forth and talk about T3 administration. People think about steroids, T4, and T3, but the T3 is sort of plus or minus, as endocrine explained to us as we had that discussion. So given the fact that he had multifactorial possible etiologies of his presentation, his age, and all of his other comorbidities, we deferred the T3 in this instance and just proceeded with T4 and steroids.
Perfect. That makes sense to me. And if this was a recent thyroidectomy, 38-year-old female, I think your risk of T3 goes lower, right? We're considering things like tachydysrhythmias, MIs, things along those lines. And this guy's coronaries probably are not the cleanest looking. He probably has some calcium and plaque deposition. And so the risk-benefit profile there is one where a conversation with endocrine and that eventual decision makes sense. And of course, it also depends on the clinical context, how the patient is responding to your earlier interventions, warming up, etc. So awesome. Fantastic work. That's a interesting case with a lot of complexity to it. Tell us kind of what happened from your initial workup and treatment in the emergency department.
So the emergency department team admitted to the ICU, and in that process, as everything's coming back, endocrine is getting on board, this patient's getting dialysis. By the time that the endocrine labs were drawn and the medications arrived from pharmacy, the patient was finishing his emergent dialysis session. Yet, he remained altered and bradycardic with heart rates persisting in the 40s. And despite being on the bear hugger through the duration of his dialysis, probably about 2 hours, he still was cold. And finally, after all this time, we were finally able to get a read on the thermometer, and he still read 93 degrees Fahrenheit. So we've done one of the biggest interventions here. We've, not only treated empirically for sepsis and sort of a couple other different etiologies, but we took away potentially that one big elephant in the room. Is this just ESRD? He got better on a previous hospital presentation just by dialysis. So maybe we were going to see something similar in this case. Yet he still remained critically ill and sick despite getting volume off and his electrolytes fixed and his uremia addressed.
Interesting. And that eventual true temperature, we've been operating under the assumption of significant hypothermia given inability to get a temperature and cool to touch. Yeah, rectal thermometers and Foley thermometers are definitely great if they're available. Sounds like it wasn't an option at the time in this case, but that's something that allows for continued monitoring. But that hypothermia, like that 93 degrees Fahrenheit after interventions to finally get a temperature, definitely increases my concern for this gentleman, knowing that, or a pearl for this case, is that the degree of hypothermia correlates with the morbidity or mortality for the patient. So sounds like he's pretty sick. We knew that already, but adding that temperature and always thinking about how temperature correlates with mortality, it's important in myxedema coma.
So he was subsequently admitted to the ICU for further management and close monitoring while receiving thyroid replacement, steroid therapy, and supportive care, including several additional episodes of hemodialysis. Last time I checked in with him, he was on the floor and doing better.
Nice. So it's a collectively good outcome in this case. That's great to hear that despite his profound hypothermia, that he's on the mend or improving and not getting worse in that area. Give us a couple pearls or sort of your thought processes, things that you took away from this case regarding myxedema coma.
Not to do a deep dive into the review right now in terms of myxedema coma, but I think overall takeaways for me was that this was a really challenging case. And as someone who, loves vignettes, who's actually, unfortunately, probably a pretty good multiple choice test taker, it's hard to not hear someone coming in altered with hypothermia, bradycardia, hypoglycemia, and a history of hypothyroidism with maybe a trigger and not immediately think, oh, is this myxedema coma, right? But I've been burned one too many times about thinking about what is this vignette sound like. So I really needed to take a step back and think about all these other differentials and diagnoses that we discussed. Is this just sepsis? Is this person, did he not have his heater on at home and was just down in his house for 4 days, and that's why it was so cold and so altered? Is it just alcohol? So I think the tendency sometimes is you just see a diagnosis, you're like, this has to be it. And I think it's so important when you have such a sick patient to take a step back and look at everything. One of the interns on my team right away was like, this is myxedema coma. And I applaud them for their ability to sort of just get right to it in terms of what their thought processes were. And, being a little bit more cautious, I felt like we needed to take a step back. And my thought process in all of this was, let's intervene where we can and reassess, and then call endocrine and move forward from there. So by the time that we got endocrine on board and we were geared and ready to give medications, as we talked about, the bear hugger had time to do its job. Dialysis had time to do its job, and he wasn't any better. And I think at that point, you can then be like, okay, I feel really good about proceeding with this diagnosis and treatment.
Absolutely. No, I think that's an important takeaway, in especially kind of early career or training as well. You sort of get these vignettes, as you mentioned, and life is never as clean in the emergency department as a multiple choice question on the board exam, right? Rarely is it as simple as a single diagnosis, and this case is a perfect example that you have alcohol involved, you have end-stage renal disease and uremia involved. We mentioned brash. Brash is still a consideration. Like, there's a lot of elements that go into it, and your team did the appropriate work of keeping that differential and just ticking things off as you go. And the data and the patient's response to your therapies is going to eventually reveal the final diagnosis.
I think just to guide us here a little bit more and just some takeaways about myxedema coma, right? It's something that we think about from boards, but it's something that is important in the emergency department for us to catch, because it's a rare but fatal condition that some people face. The mortality with myxedema coma is reported from 20 to 25% to as high as 60% in some studies, even with intensive care. So when we talk about emergencies, right, this is an endocrine emergency. It's one of those that you call the endocrinologist overnight, like we did in this case, and go, hey, wake up. We have an interesting case for you and we'd love your help. Making sure you take something like this super seriously. Now, we kind of hinted at it in the case, but it is more common in females and it's common in individuals over 60. And interestingly, it's also more common in the winter. So kind of thinking about your epidemiology and your demographics for this. So for this man, it's a little bit in left field, quote unquote, for a guy like this to come in and that be his diagnosis. But you do have to kind of keep it on your radar. And really anyone who comes in with altered mental status and hypothermia.
That makes sense. And I think as you talk through that as well, the final point that you don't want to miss is why. Like, why did they go into this state? And, we talked a little bit about his medication and his medication reconciliation. It could be simply not having his supplement of Synthroid. It could also be other medication effects. There's a long list. The ones I keep in mind are, amio and lithium. But and the answer may be we don't know exactly what the root cause or precipitant was, but not forgetting about that. When you diagnose DKA, you don't just diagnose it. You try to find what the root cause to it could be, because if you're missing the underlying sepsis, the profound UTI, or other precipitant to the DKA, then you're leaving the person in a worse spot as well.
Yeah, absolutely. Ultimately, it's just disrupted homeostasis in a hypothyroid patient. So as you said, there's a precipitant, and it's our job to figure out what it is. And the interesting thing is sometimes those triggers and symptoms can kind of overlap. Sometimes it could be hypoglycemia that sets them off, or hypothermia, or as you said, something more simple as an infection. Sometimes it really is hard to piece apart what is the trigger and what is just a symptom of this presentation. I think we've been sort of talking about different parts of the presentation piece by piece, but I just want to lay it on the line here just so people have a clear picture of what myxedema coma could look like. It's most commonly a female patient presenting in the winter with a history of thyroid disorder and some sort of precipitating illness. It's that person coming in with altered mental status and hypothermia. That should ring alarm bells when it comes to your differential diagnosis and this being potentially on it. You want to think about really hypotension, bradycardia, hypoglycemia, hyponatremia, and hypoventilation. All of those are components of this presentation. Now, from a neuro perspective, we love to talk about coma, and it really is a misnomer, as it's not a very common neurologic manifestation of this disease. Rather, it can be really any sort of deviation from normal, whether it's depression, disorientation, all the way to psychosis and agitation. And rarely, in some case reports, there have been seizures linked to myxedema coma. So coma is definitely not something you should latch onto when it comes to this diagnosis. Now, I think when you talk about hypothermia, it sort of makes sense. We know that thyroid is important to metabolism, so without thyroid hormone, you're not creating heat, there's no thermogenesis. And I want to reiterate it here. The severity of hypothermia is related to mortality. So the lower the temperature, the more likely a patient is to die. Now, we've talked about a couple other key parts of this presentation. You have bradycardia and hypotension. Without thyroid hormone, your heart is not contracting. There's alteration in your conduction. You get your bradycardia, you get hypotensive, you get shocky. From hypoglycemia, is it the alcohol in this case? Who knows? But at least with severe hypothyroidism, it could be caused from hypothyroidism, or as we've hinted, that concurrent adrenal insufficiency, right? So you have to make sure that you're not masking adrenal insufficiency with your hypothyroidism. And then ultimately hyponatremia, it's a key finding. So it wasn't present in this case, which I think we can attribute to the patient's ESRD.
Yes.
Right. I think is probably the thing that maybe is preventing his kidneys from acting normally. But typically, approximately a half of patients with myxedema coma have hyponatremia. And it can be pretty severe. It can contribute to this decreased mental status that we see with myxedema coma. So it wasn't here in this case, but keep that in mind. If you see hyponatremia, don't just think the hyponatremia is the cause, especially if you have other vital sign abnormalities like hypotension and hypothermia.
That all makes sense. And you mentioned all of the hypos, right? Everything is slowed down. Your mental state can be slowed down. The idea of psychosis and agitation, man, that's going to be a tough diagnosis to make for myxedema coma. But neurologically slowed, you're hypothermic, you're bradycardic, you're hypotensive, you're hypoglycemic, you're hyponatremic. All of the hypos, everything is slowed in this state.
And you see that even on some of the diagnostic tools that you may use to figure out this diagnosis, right? That EKG, you can see bradycardia, you see variable blocks, you can have QRS widening, you can have a prolonged QTC. Thinking about that elongation and slowing of your EKG with hypothyroidism. I guess thinking about diagnosis a little bit more, we've hinted at it, and I think a lot of people, for the most part, understand how to diagnose hypothyroidism, but it can be a little tricky with myxedema coma, especially given how severe a disease and disease process it is. We know what we're looking for. We're looking for a low T4, a low T3, and that elevated TSH. That's very classic for what we consider hypothyroidism. But we really have to keep myxedema coma on the differential, especially if you have a high suspicion for it, even with a normal TSH. And that's because, one, TSH elevation is not always an indicator of the severity of hypothyroidism. The literature really shows a wide range of TSH values in the literature. So we noted that in this case, the TSH was 9, but that doesn't necessarily mean he doesn't have bad hypothyroidism or his hypothyroidism isn't super severe, right? I think that's one key to kind of take away. And two, we can't forget about central hypothyroidism. This TSH could be normal, but that could be inappropriately normal for an absent thyroid hormone. Your pituitary is not producing TSH in response to a low T4. So you don't want to miss this diagnosis because you're looking for that TSH. So I think in general, anytime that you're suspecting myxedema coma or it's something that could be on the differential, just send them both. Because some labs do reflex, and if it's not elevated or abnormal, you're not going to get that repeat study.
Yep. Yeah, we have a TSH with a reflex T4, but I routinely, when your clinical suspicion is high like that, you're just pulling the trigger in all of these capacities because this creates such a mixed picture we've already talked about, and the differential is usually relatively broad, at least to start. I mean, starting with that total T4, the free T4, T3, and the TSH, no one's going to fault you for getting that data to help further delineate the patient's pathology.
Absolutely. I guess in terms of treatment, I think this was sort of a learning point for me too in this case, is really the order at which these things are done. You kind of think about adrenal insufficiency when you think about hypoglycemia and hypotension, but then when you think about hypothyroidism and myxedema coma, you're like, oh, I have to give thyroid hormone. And your gut reflex isn't to think about cortisol, right? And I think that was something for me that was a key takeaway. When endocrine was like, yes, let's make sure we give the hydrocortisone before you give the thyroid hormone. And they walked me through it, and it makes a lot of sense. So the thyroid hormone, when you give that back, one, it can actually increase cortisol metabolism. You could even precipitate an adrenal crisis in someone who maybe has borderline low cortisol levels by returning that thyroid hormone. So by giving that hydrocortisone up front, you're preventing that from occurring. And then, as we've talked about, you could just have adrenal insufficiency on board. So why don't you just do both at once and cover for both of these possibilities by giving the hydrocortisone up front? And as we said, that's the stress dose, quote unquote, version of this medication, which for many people is going to be a 100 milligram IV loading dose. And then I guess in terms of levothyroxine, we know that we're going to give T4, and that's something that you can work with endocrine to get the appropriate dose. The spectrum can range from 200 to 400 micrograms, and work with them to figure out what the appropriate dose could be for your specific patient, because it's going to differ based on their comorbidities and based off of their illness severity. And then we sort of been hinting at T3, and the evidence on it kind of goes back and forth. The current guidelines give pretty weak recommendations for T3 use, and they really recommend caution with really anyone with underlying heart disease, given a risk of arrhythmia and MI, and the associated increased adverse outcomes in these patients. So I think talking to endocrine and be like, hey, is this a patient that we should be giving T3 to, even if they're super sick, I think is an important part of the discussion, because it isn't a benign medication, especially when someone has a multifactorial presentation like this guy here. Are we doing the right thing by doing the gamut of these medications, or could we be causing harm?
That all makes sense. Yeah, those are tough decisions to make. And not ones to be taken lightly, usually done in consultation with our endocrine colleagues.
Ultimately, when we pass off to the ICU, and I think want to reiterate, this is going to be an ICU admission. This is a sick patient, and myxedema coma has a high mortality, and they're going to need frequent monitoring and reassessment. So the disposition here is ICU. And ultimately, your ICU colleagues are going to be following the T4, they're going to be following the T3 and TSH, and looking for improvement in mental status or cardiac function and pulmonary function. And those are the therapeutic endpoints. It can take up to a week for someone's mental status to improve when they have severe myxedema coma. So it could be a long hospital admission for them. So prepare them and their families for it.
Wow, I didn't know that time to resolution of symptoms, that is a long stay for sure.
I think just some key takeaways here as we think about this case. So 1, put myxedema coma under differential for anyone presenting to the ED with hypothermia and altered mental status of really any kind. 2, hypoglycemia, bradycardia, hypotension, hypoventilation, hyponatremia. So thinking about all those hypos are common associated features. The diagnosis, this is number 3, diagnosis is made using TSH and free T4, as the level of TSH does not correlate with the severity of hypothyroidism, and you could be missing central hypothyroidism. 4, treat with stress dose hydrocortisone, followed by IVT4 plus or minus T3 when you have high clinical suspicion. You really should be intervening the moment that you have clinical suspicion for myxedema coma. And then 5, get your endocrine team on board early and admit to the ICU, given this is an endocrine emergency associated with a high mortality that increases with worsening hypothermia. And I think those are the key takeaways that I'm going to take away from this case moving forward into the rest of my clinical practice.
Well, awesome, Dylan. I completely agree with those takeaway points. This is a very challenging diagnosis. It's challenging for people that can get a TSH and maybe even a free T4 in real time. Even in those circumstances, we have challenges, but we don't want to ignore the listeners that can't get a TSH to result for hours or days. And so that adds even further wrinkle of complexity in the logistics of taking care of these patients, and really makes you put your money down on your clinical suspicion to empirically treat a patient that you suspect profound hypothyroidism or myxedema coma. But thank you so much for bringing this case to light. Great differential to work through, and really, really interesting disease process to manage. SimKit is always there for you to help you improve or maintain your procedural skills, and we do all the heavy lifting. No more scheduling with a sim center, finding small groups at a conference. Have your procedural training delivered to you in small 30-minute installments once a month that deliver right to your home, office, or emergency department. Keep your patients safe and combat skill set decay with a SimKit subscription. Click the link at the bottom for more.